Hello, my name's Peter Acker, and I'm joined today by Dr. Matt Strelo, who's a clinical associate professor and the co-director of Stanford Emergency Medicine International. So thank you for being here, Dr. Strelo.
Thank you for having me.
Absolutely. So today we're going to be discussing a case of anaphylaxis. We had previously highlighted some of the case details, and now we have our expert here to delve into some of the teaching points. So we'll watch the first part of the case and discuss.
Focus, Henry. What do you hear? What do you hear?
I'm not sure.
This man has a pneumothorax. Come over here. I'll show you how to put it in a chest tube.
I'll grab a tray.
Yeah, I bet it hurts. Just hang on there, buddy. Everything will feel better in just a minute. Okay, Henry, first thing that you want to do is feel for the ribs. Along the mid-axillary line, locating the fifth inner space. Can I get some betadine? Where you make the incision.
I'm not feeling so good.
What?
I'm feeling so good.
Well, sit down. Put your head between your knees. Lily, give me the Kelly. How you doing, Henry? Lydia, do me a favor. Slide Henry out of the way.
Carter, he's a little cyanotic.
What?
Can't get a pulse on the banger.
Lydia, call an attending.
All right, so our patient here is a 20-something-year-old male who was apparently healthy initially, was in the emergency department as a student and watching his resident perform a procedure, and then mentioned that he was feeling unwell, and then we saw him collapse to the ground where he appeared to be unconscious, and the nurse found him to be cyanotic. So speaking in generalities, when you come upon an unconscious patient, what are the first things that you want to do?
Well, I approach the patients pretty systematically, so I don't forget or miss anything major. And so when I come across an unconscious patient, especially if I have no, previous knowledge of that patient, I'm going to start with just my general assessment ABCs, my same initial assessment on every patient. And so the first thing I'm going to do is just walk up, take their initial impression, and then I'm going to start right into feeling for a pulse while I try to arouse them and see their responsiveness.
Excellent. So you're already assessing their general appearance and their level of consciousness, and then moving on to the ABCs.
Yeah, and whether you use the CABs, the circulation, airway, breathing, or the ABCs, it really varies, on whether you changed your practice when the American Heart Association changed their guidelines. And the international community is divided on this, and so I don't think it matters that much, to be honest with you, as long as you do them very rapidly, regardless. And so you need to get down to checking circulation very quickly is the key thing there. So either ABCs or CABs, kind of less important than just making sure you're getting these things done quickly.
Sure. So it sounds like rapid and systematic are the key points.
Yep.
When you were observing this patient prior to him collapsing, was there anything you noticed about him that's triggering your thought process?
Well, we had a little bit of an advantage there versus, I think, the other providers in that room, because the other providers in that room looked like they were caring for a very sick patient at that moment. And so they weren't paying attention to what was going on with each other. But we had the opportunity to kind of be watching from, the grandstands and noticing that person who collapsed, that gentleman who collapsed, he was grabbing at his throat a lot, which is concerning. He looked like he was trying to clear his ears, grabbing at his throat. He didn't look like he was communicating or feeling quite right, and then he started itching his arm prior to going down. And he went down kind of slowly. It wasn't really a drop, instantaneous attack. It was very quick as far as, within less than a minute, but it wasn't from normal to completely unconscious like that. He kind of went down a little slower than that. So we had itching, grabbing at his throat, and then in the course of maybe 15 to 30 seconds, collapsing.
Excellent. And do these items help craft maybe the top 3 items on your differential, or the things you're maybe thinking are most likely?
Well, I think that anytime you have an unconscious patient, you got to keep your differential somewhat broad to start with. And really, although you should be evaluating, thinking, acting simultaneously, you're going to focus on your evaluation and actions a lot. But as far as your differential goes, in a young person who's itching and then collapses and is seems to be grabbing at their throat a little bit, you're going to think about airway obstruction. You're going to think about anaphylaxis, and airway obstruction may be a component of that as well. I think you need to, we didn't see any seizure activity, but you should definitely be thinking about seizures in a young person that's going to that collapses suddenly like that. Other things that I would probably add to that list would be cardiac syncope. So if the patient went into a dysrhythmia, you will oftentimes they won't collapse immediately, but they will actually kind of start to wobble a little bit before they go down, because there is this time period where they're still having some perfusion before it really gets to the point where they're unconscious.
Excellent. Well, thank you. Let's see how the case unfolds.
What happened? Banger at attention pneumo. Henry passed out.
All right, I'll finish the chest tube. Get your student in the trauma tube.
Okay. Henry, you're gonna be just fine. All right, everybody grab hold. I'm gonna count 1, 2, 3.
What happened?
I don't know. I was showing him how to put it in a chest tube and he just fainted. Go on the other side.
Wheezes bilaterally.
Pulse ox is 86.
So in that last clip, we see that the patient was placed on a transport board and was being moved to a resuscitation area for further evaluation. On the way over there, it looked like someone had placed an IV and the team was putting him on monitors. And one of the female physicians had started a cursory exam and had mentioned she had heard some wheezing on the lung exam. So thus far, would you be able to comment on what the general appearance and level of consciousness, as well as just the ABCs, have shown us for this patient?
So the patient there, it looks like they didn't think that they were protecting the airway. The patient wasn't very responsive. I don't think anyone had actually gone and looked into the airway at this point. They did appear that they had a pulse at this point. Is that correct?
It did appear that way, yeah.
And then they did the breathing as well, and on the breathing they found that the patient was breathing spontaneously, which if you're breathing spontaneously you generally have a pulse as well, and was wheezing. So this does affect our differential a little bit. I think one of the things I didn't mention previously was just a simple vasovagal syncope is probably the most likely. I really went through the life-threatening differential before. But once you start finding a patient with either prolonged unresponsiveness or other objective findings like wheezing, I think vasovagal syncope or neurocardiogenic, which is his other name, kind of becomes less on your differential and goes rapidly down on your list, and you need to start thinking about other things.
And we've obviously found some abnormalities on the ABC exam. Do you mind telling us what your initial interventions might be for this patient?
Well, clearly, as long as you have a pulse, you're going to then start with your ABCs, and stabilizing that airway is going to be a major player. And that is especially true if you're thinking about things like allergic reaction and the anaphylaxis, because of the potential for swelling and making that a complicated procedure. So evaluating the airway thoroughly, meaning is there a gag reflex, is there signs of any obstruction or any kind of swelling that's going to make it a difficult airway to manage if you have to, would be my first intervention. Dealing with the breathing component, we're probably going to do things simultaneously if possible. We are going to do systematically, but if we have multiple providers in the room, we will do things simultaneously. So we'll probably put the patient on oxygen. If they're wheezing significantly, you might consider like an asthma type medication, an albuterol or something like that. But I think at this point, that's not really probably your key intervention. I think really your key intervention is probably putting them on oxygen in addition to managing the airway, and then supporting the circulation. So at each stage, when I go through that initial assessment, I'm going to start an intervention if I see a problem.
Absolutely.
Right? You don't want to go through, do your full assessment, and then begin intervening after that. This is the emergency medicine approach, so we're going to do things simultaneously. So on the circulation component, as we're working on A and B, we also know the patient has, if they do have a pulse, it's probably a weak pulse, they're hypoperfusing, they're unconscious, so you can assume they're probably hypoperfusing. And at that point, you're going to start getting some sort of access because you're going to want to support that circulation as soon as possible.
Excellent. So a means of giving fluids and medications as we deem appropriate.
Yeah, and I think putting that patient on the cardiac monitor is going to be really important too, right? Because one of the things in our differential was a cardiac dysrhythmia.
Absolutely. All right, well, let's see what happens next.
I need to intubate. Junior, give me a laryngoscope. Come on, let's go!
Did he complain of feeling sick?
He's always complaining. He's a hypochondriac.
Is he on any meds?
Not that I know of.
Okay, let's get a CBC, Chem 20, and a tox screen.
All right, I'm in. Bag him.
Pulse ox is worse, down 82.
What? Carl, get a blood gas.
Pressure's crashing.
What the hell is going on?
So in that last clip, the patient was intubated by the male physician and was being bagged by one of his colleagues. And the female physician was asking a couple of historical questions to try and gather a little bit more of the picture, and was requesting a couple of labs. So at this point, they then noted that the patient's blood pressure was declining further and the hypoxia was worsening with saturations in the very low 80s. So now that we've gathered a little more information, how would you just generally describe this patient's condition?
Well, the patient's critically ill. I mean, this is a patient that's in shock, right? Clearly in shock. The blood pressure's dropping. The patient has altered mental status. So you have a critically ill patient on your hands. And, you mentioned the patient that getting labs. I don't know what hospital they work at, but I know that in my hospital, labs are going to take a while. And I think they will at any hospital, even if you're using a bedside lab test. So although it's nice to grab those, that's not really going to be my major intervention or what I'm hanging my hat on at this point. I've got other things that I need to get done first, and that's to support the patient.
Yeah, it does seem like that is a less effective intervention at this point. Now that we've seen this patient progress and sort of declare themselves as a very sick patient, are there items that are moving up or down your differential diagnosis?
Well, I think, at this point you can pretty much take off the non-concerning conditions. So neurocardiogenic syncope or vasovagal syncope can kind of come off the list. I think that anaphylaxis or allergic reaction needs to go up the list. I think that a cardiac dysrhythmia potentially needs to go up the list as well. And then it's very interesting that the patient had, wheezing. That's a tough one to try to figure out exactly what's going on. So potentially like a foreign body or obstruction of some sort, which would be very odd in this. But to be honest with you, this is an odd presentation. This patient very rapidly decompensated.
Absolutely. The female physician during her assessment was asking for a little bit more history, and unfortunately none was available at this time. If there were a bystander or a paramedic or a family member, are there any key pieces of information you'd be interested in?
Yeah, I think given the patient's itching, right, and their rapid decompensation, you really need to be thinking about anaphylaxis, and then you're also going to ask some questions about the cardiac history. So for anaphylaxis, I'm going to ask, is there a history of allergic reactions? I mean, most of the time, patients have an allergic reaction and end up in our emergency department, or my emergency department. They have a history of allergic reactions. So, that's the first thing. Does this patient have a history of these kind of medical illnesses? Next thing I'm going to ask is, if they do have a history of allergic reactions, how severe were they, and what are they allergic to? And then you're going to ask, I think, about other major medical conditions, because if this patient's had cardiac surgery, if this patient has a history of hypertrophic cardiomyopathy, anything like that, any cardiac history as well, that's going to change or at least alter the order of your differential. So it's going to be a lot about kind of allergic reaction history. It's going to be about the medical history as far as the cardiac history. And I might throw one other thing in there that's probably really important on history, is any medications, and that goes along with allergies to medications, but medications in general, and then any history of taking any illicit drugs or non-prescribed medications, because those obviously, in a young person who collapses and is altered, that's got to be reasonably high in your differential. It's a little different maybe in this case, because the patient was working, was acting normally beforehand. But if somebody's just wheeled in front of you, I think illicit drug use has to be on that differential pretty high up.
Yeah, so it seems like focusing on the really high yield topics, the medical history, allergies, medications, but not delving into too much extraneous information for these sick patients is really key. For this patient, as you mentioned, they had been asking for a couple of labs. I think she asked for a tox panel, a chemistry panel. As you mentioned, those probably aren't very timely and may not provide that much information. However, are there any other testing or imaging modalities that would be helpful in this very ill patient?
Well, that's a good question. I think that, if you had the time, could you get like a blood gas? Maybe. But I think I'd get a glucose right away, right? This is a patient who has, altered mental status, was acting looked a little bit pale or sick beforehand. Maybe they're hypoglycemic, so I'd put that high on my list. I'd love to get a bedside ultrasound, if at all possible. I think that one of the things that's revolutionized management of the critically ill patient, both in the emergency department, but also inside the hospital, in the ICU and other places, is the use of bedside ultrasound to kind of help evaluate our differential diagnosis. And there's pretty good studies out. There's some good studies out there showing that we can, go through our differential faster and more efficiently and be more correct with the use of bedside ultrasound. So that'd be one. You might consider a chest X-ray, but that again is probably not going to be a timely enough intervention. But because of the wheezing.
Absolutely. And I thought, although we likely have the patient on a cardiac monitor, an ECG might be something.
Yeah, I think you definitely want to get an ECG. Yeah.
Okay. Well, let's see what they do here.
His wrist is red. His left hand is red and edematous.
Right hand's also swollen.
Oh my God, he's allergic to latex.
So in that clip, the treating physician notices the patient's hands are very red and edematous. He's wearing gloves, exam gloves, and he raises the concern that this could be an allergy to the latex in the exam gloves. So at this point, based on our prior differential, do you think that we need any confirmatory testing, or do you feel like allergic reaction is likely the cause of his symptoms?
Well, I don't think there's great confirmatory testing that you're going to do for an anaphylaxis or allergic reaction, but at this point, you're pretty much committed to that diagnosis, I think. And you're not. I'm rarely 100% in the emergency department, like confident in my diagnosis, but once I get into the 90s, that's good enough. And we're going to be moving forward treating this patient, I think, like they're in anaphylaxis. At this point, they've had some itching, rapid collapse, wheezing, they're hypotensive, and they have rash, right, and signs of potentially urticaria. So at this point, that patient has anaphylaxis until proven otherwise.
Absolutely. So as you mentioned, there is really no confirmatory testing for an allergic reaction, but this patient does meet the diagnostic criteria in that he has a likely allergen exposure and low blood pressure, which is enough to define this as anaphylaxis, but he also has an allergic exposure and greater than 2 organ systems involved. So I think, as you said, we would just treat presumptively with a diagnosis of anaphylaxis. And I was just curious, what are sort of common causes of allergies that you see in the emergency department and severe allergic reactions?
Well, the most common cause that we see in the emergency department is going to be an allergic reaction anaphylaxis due to medications. So medications are probably number one cause, and then after that, probably food allergies. But the vast majority are medications. In pediatrics, they're probably reversed, So in pediatrics, food allergies are going to be more common, and that's probably just a simple reflection that few children are on medications, right? And so, due to the food allergies in kids probably being a little bit higher and the medications being lower, you see that flipped.
Excellent. And it looks like, fortunately, latex allergies are less common, maybe less than 1% of the population suffers from that, but not entirely uncommon, so definitely something that we have to consider for this patient.
Yeah, I think definitely in a healthcare provider as well, because although latex allergies may be uncommon in the general population, especially healthcare providers that work in locations where they use a lot of latex, actually that increases your risk of having a latex allergy. So in a healthcare provider, either working in the past where there was a lot of latex used in the United States, or working outside of the United States where there's still a lot of latex used on a regular basis, it's going to be higher. Definitely.
And now that we're honing in on a more refined differential, would you be able to talk about critical medications for this patient? What should we be giving him medication-wise, maybe the route and dose for the initial meds for him?
Yeah, I think that the medication to give to these patients is pretty well established and pretty clear. You're going to give this patient adrenaline, or epinephrine is its other name, but adrenaline is the cornerstone of therapy in managing anaphylactic reactions or anaphylaxis. And if you're not giving adrenaline, you're not doing what you need to for these patients. And as far as route goes, route is has evolved over the last, I would say, 5 to 10 years. If studies have come out and shown that an intramuscular route is superior to the subcutaneous route, and it's not clear that IV is really a lot better than IM, and IM appears to be safer. So intramuscular is really the way to go. And normally what we use in the United States in an adult is going to be 0.3 milligrams of the 1 to 1,000 solution, because you want to just think about it as a low volume, right? So you're giving it IV, you want to use a high volume to not make a mistake. If you're giving it sub-Q or IM, you're going to use low volume solution. So that's going to be the 1 to 1,000.
Excellent. There's also a lot of medications that people speak about for these allergic reaction patients that seem more adjunctive. Would you like to tell us what we might hear about as far as other medications to give these patients?
Yeah, so these are not medications in which I'm going to stop other things that I'm doing for this patient, because you're not just going to give this patient adrenaline. You've got to support their cardiovascular system, and so you're going to be working on the other shock aspect of care. And I don't know if we're going to talk about that later, but things like IV fluids and airway management, stuff like that. But as far as the adjunctive medications that you're going to be giving that are targeted more towards an allergic reaction rather than the patient's shock, it's going to be things like steroids, antihistamines, so H1 and potentially H2 blockers would be the big ones. Some people, if the patient is on like a beta blocker, they might also add a glucagon to that patient's management. But for the most part, the steroids, the H1s, the H2s, those medications are really targeted towards either, in the case of the antihistamines, targeting more the kind of the symptoms, the itching, the flushing, the redness, the rash. And the steroids are targeted towards the late phase reactants of an allergic reaction. So none of those are really helping your patient in the short term. And that's why I said, as far as the steroids, the antihistamines, you do want to give them. And I think we do give them early, but we don't allow the administration of those medications to interfere with critical other interventions like the adrenaline, like aggressive IV fluid boluses. So this is someone you want multiple IVs, you want to be bolusing them large volumes of fluid, liters at a time potentially, and then you really want to be managing this patient's airway.
Absolutely. And I think one other medication that sometimes makes its way into the adjunct category is a beta agonist, which you had mentioned before, which can sometimes help with some of the wheezing, but is most definitely an adjunct. It doesn't help with the low blood pressure, and it doesn't help with the airway edema, so it's not something that's going to save a life, and definitely should not interfere with the critical interventions that you'd been touching on.
Yeah, you might get a little bit of dilation of the lower airways with the beta agonist, which is good. I mean, you want to be able to move the air as effectively as possible, but at the end of the day, patients with anaphylaxis generally don't die from lower airway problems. They're going to die from upper airway problems or cardiovascular collapse.
Definitely. So let's see how the case progresses.
Okay. He's in a systole. Ample heavy. IV push.
ET tube cup has latex. We've got to extubate. Really, get me an ET tube from the latex, sweetheart.
Wash your hands first. Choonies, do me a favor, give me a basin of water.
Found a non-latex ET
Give me a meg of atropine and 50 of Benadryl.
All right, so in that last clip, things progressed. The patient was noted to go into asystole on the monitor, and the treating physician asked for 1 amp of IV epinephrine. He started performing chest compressions, and his colleague had recommended re-intubating the patient. They had mentioned a potential concern that the endotracheal tube contained latex, so wanted to remove the allergen. During the CPR, they also asked for some atropine and Benadryl. So just in generalities, for patients who are in asystole, what are the initial interventions that you'd provide?
Well, asystole is a bad place to get to for the most part. You don't see patients often collapse like this and go to asystole. There are allergic reaction interventions or anaphylactic interventions that they were providing. I think removing the allergen exposure is important for management of anaphylaxis, whether it's a bee sting or whether it's latex in this case. But I think by the time you're at asystole, you're really focusing on coding the patient, right? And you're going to use follow guidelines, and which are mostly evidence-based guidelines. We use a lot of the advanced cardiac life support care, and with that for asystole, it's really a matter of doing the best CPR you can. So really good chest compressions in CPR, which are effective chest compressions, and then trying to optimize those chest compressions through monitoring when you get to that point, meaning putting in an art line or making sure that you're actually getting that perfusion pressure up, because you want to get that perfusion pressure, the diastolic pressure up. If you can get that diastolic pressure up over 40, and that means you'll help perfuse the myocardium, and you'll give a chance that heart may come back. Now, with the CPR, though, the other thing that we tend to add in asystole is adrenaline, or epinephrine again. So, I think they gave that in this case. Is that correct?
Yes.
So we do want to add adrenaline to these patients. Is adrenaline going to be effective? Does adding it help? I think that's debated at this point. But it's still, I would say, pretty much still standard of care to give adrenaline in these cases. I think you will get more return of spontaneous circulation. We have a young patient who should be getting adrenaline anyways, so I'm definitely going to give it in this patient. And then as far as whether to give atropine and other things like that, I don't think that they're necessarily indicated anymore in asystole. They've kind of been taken off the board to kind of simplify it and focus on the things that are most important, which are your CPR and plus or minus your, with your adrenaline, and then you're going to manage this patient's airway.
And we already had a very ill patient, and we discussed some of the potential causes of his illness. Does your differential change at all for a patient who loses their vital signs just after being intubated?
Oh yeah, definitely. So if, interestingly enough, they were going to switch the tube out in this patient, and I think that that's got to be, this patient was already crashing pretty closely, or pretty close to crashing, but anytime you have a patient who's intubated, especially if they were just intubated, your number one thing on the differential has got to be kind of the dislodged or inappropriately placed endotracheal tube, right? Because what are you going to see in a patient like that? Those patients are going to be, they're going to get bradycardic as they get hypoxemic, and then they can go into an asystole. So that's got to be high on your differential, And then I think the other things I use kind of the other things I think about is whether the endotracheal or the airway circuit is obstructed, which is going to give you that same sort of pattern. Okay, and that can be blocked in anywhere in the circuit, from secretions or from a kinking of the tube or from whatever, or somewhere even in, in the circuit to the ventilator. So this is a patient who you're not going to have them on the ventilator at this point. The minute you see that, the first thing you're going to do is take the patient off the ventilator, let air out, if you can, of the ET tube, and then you're going to try bagging them. And you're going to make sure that you confirmed ET tube placement, because I'm not sure that confirmation of ET tube placement was done well. I don't know, maybe we didn't see it in the video clip, but I definitely spend more time confirming my tube placement than they did here.
And how do you like to do that?
The first thing I do is I make sure that when I look, I see the tube go through the cords, and that's the number one thing, right? So immediately whether you have a high risk for an inappropriately placed tube, if you couldn't see the cords well and you couldn't see that process, or you have a low risk where you saw it very clearly. And then the next thing I'm going to do is I'm going to listen. I'm going to listen to the bilateral, I'm going to listen kind of in the axillary area, both sides, and I'm going to listen over the epigastrium. And you're going to listen for good breath sounds on both sides, and you're going to listen for no sounds of borborygmi or any kind of air or bubbling in the epigastric area. After that, at our institution, we have a policy now where we confirm everything via end-tidal CO2. And we use continuous waveform end-tidal CO2. We often used to use the color change, the capnography, but and that's good. It's definitely better than not doing anything, but I like that continuous waveform.
That does seem to be the most reliable of all the forms of tube confirmation.
It does, and it sticks with you. So, one of the things that we've seen is that patients have it in the right place, and then you saw all the things going on around that case, right? And as things are getting jostled around, if that tube is kind of not quite all the way in the right place, or there's something like that, it might become dislodged. And you're not going to pick that up if you use color change. You will pick that up if you're using continuous end-tidal CO2 monitoring.
Yeah, definitely one more benefit. While we're touching base on airway management, you had mentioned earlier that planning for this particular type of airway management is a special consideration because of potential upper airway edema. Do you want to just go through how you would plan for this type of airway management and what would be in your plan?
Well, I think, in this case might be a little dramatic or a little bit tough to plan because this happened really quickly. But in general, you are going to have a little bit more time in an anaphylactic allergic reaction patient, potentially. And if you do, you want to consider doing an awake intubation, if possible. I think that you want to take a look, if possible, before you take away that patient's ability to breathe and ability to protect their airway through rapid sequence intubation or the medications used to paralyze the patient and sedate the patient, then you're going to want to take a look if you can. And so using like a flexible scope or something to take a look and see how difficult the airway looks like it's going to be, potentially anesthetizing them a little bit, trying to even do an awake intubation might be a good way to go. If you're very unfamiliar or uncomfortable with that, you may not want to do your first case in somebody with edema, right?
Yeah.
So that's why you got to practice these things in advance. Barring that, though, you're going to move down to managing the patient in kind of something that you're comfortable with, which for most of us is going to be either RSI, or in this case, if the patient is already completely flaccid and unconscious, if they're flaccid, then you're going to go ahead and, I think they just move directly to intubating the patient, which is okay, but you have to plan for failure in this case, unfortunately, because these are really high-risk situations where you may not be able to see the cords. You may not be able to see anything when you get in there if there's enough swelling and edema, right? That patient was grabbing at his throat and looked like they were having trouble breathing. So, at this point, you better be ready for failure. And when I mean ready for failure, the way we treat airway management failure is with a knife, or as like some of my friends like to say, with cold steel, which means you stick a scalpel into the lower down and you do a cricothyrotomy. So you got to be ready for a surgical airway in this patient. And you should probably, before I'd intubate this patient, I would actually feel, if I had a second, I would feel where I'm going to do my surgical airway. I would mark it with a pen. I would get all my supplies out and ready. I mean, that's how serious I would take it. I would be ready to do it in a heartbeat if it just didn't come around.
Surgical airway management is something that gets discussed a lot, but it does seem like this, of all types of cases, is the type where you want to have your kit open and be totally mentally and physically prepared to use it with a very low threshold, as they're going to be very difficult intubations.
Yeah, I think that, the thing is a lot of our airway adjuncts that we use, the laryngeal mask airway, the LMA, a King tube, a combi tube, all of these things aren't going to get you past that obstruction. So if you've got edema from an allergic reaction, or you've got obstruction from trauma or something else like that, your backups in general don't exist except for surgical airway. They're not functional in the same way they are with other patients. So in those cases, you really have to be ready immediately to do that.
Definitely. Well, that's very insightful. Let's see how the case proceeds.
Laryngeal edema. I'm having a hard time getting in.
How long has he been down?
30 seconds. Damn it.
Watch his teeth.
I know.
You see the cords?
Barely.
All right, Malik, high dose epi, 7 cc's. You're doing great. Just keep sliding it in, very gently.
I'm in.
Great, good job, good job. Got a pulse.
Woo! Everything okay here?
So in that last clip, they were fortunately successful in their attempts to reintubate, although we do hear the female physician mentioning there's a lot of laryngeal edema. So as we were predicting and concerned about, this was a difficult airway, but they were able to perform direct laryngoscopy successfully. They were continuing with CPR, and it looks like gave the patient what they describe as 7 cc's of high-dose epinephrine, which we'll assume is 1 to 1,000 epinephrine. And fortunately, the patient got their vital signs back. They regained a pulse. So I just wanted you to comment on that dose of epinephrine. It sounds like may have been up to 7 milligrams of epinephrine. Is that an appropriate dose for this situation? And if not, what would have been a more appropriate dose?
Well, high-dose epinephrine has come in and out and back in and out of style, and it is currently out of style. So high-dose epi, or high-dose adrenaline, I should say, as well, or 7 milligrams would definitely be high dose, right, is now no longer recommended because we haven't been able to show improved outcomes from it. There's some question of whether you might get a few more patients to have return of spontaneous circulation transiently, but outcomes definitely aren't better. In fact, they could be worse with high-dose epi because the people you do get back do neurologically worse. So we want to avoid high-dose epi, and so 1 milligram of epinephrine IV is the code dose, and that's the 1 to 10,000. Remember, we're going to use the diluted, the larger volume in these cases when you're giving it IV. And that's really standard in an adult, and I don't go above that. I do give it, every 3 to 5 minutes. You want to stay on top of that, but you don't want to be using 7 milligrams anymore.
Okay. Outside of the cardiac arrest setting, how would you use epinephrine for a patient with persistent shock or persistent symptoms?
From anaphylaxis?
Yes.
Yeah. We probably both had cases like this, and I'll tell you that I try to avoid moving directly to IV right away, okay? I try to use IM. We've all had cases where IV was given, whether it's by us or in the pre-hospital environment, and the patients have had a complication, such as an acute myocardial infarction or some other complication, a dysrhythmia. And so I think we want to try IM, but if I've given repeated doses of intramuscular epi or adrenaline at that point, I'm going to move to an IV drip. And so I will put the patient on an IV infusion of adrenaline then. And that way I can use a lower dose. And what I'm trying to do is avoid a huge spike from like a bolus intravenously. And so if I'll put the patient on a lower dose drip and then titrate that up rapidly to when I get the effect that I need, which is stabilization of the cardiovascular status.
Yeah, I think you brought up some very good points there in that this is an essential drug but has a very narrow therapeutic window when given intravenously. And so we try and avoid it if we can with repeated IM doses, but if it is going to be given IV, a drip is definitely preferred to a bolus dosing where mistakes are more easily made with dose calculation. But titrating for effect does seem to be the theme. The literature doesn't really seem to support one particular dosing strategy, but I've seen anywhere from 2 to about 10 micrograms per minute as the initial dose and then titrating for cardiovascular response.
Yeah, and I think you can titrate that up. I've had success in that 10 to 15 microgram per minute range with anaphylaxis cases. You can go higher, but it's really you're just at some point you're ceiling out on your effect is what's going to happen.
Right. Well, this was a very sick patient that fortunately they got some medication to and seemed to improve here, but I think highlighted a lot of the essential teaching points that we wanted to for this case of anaphylaxis. So thank you very much for your time, Dr. Strela. Really appreciate your expertise.
Thanks for having me.
Absolutely.